Dr. Judith Flores is a board-certified pediatrician and executive health leader with more than 30 years of experience in public, voluntary, and community healthcare. A New York, Puerto Rican raised in Central Harlem, she earned her BS in biology from Fordham University and her MD from the Icahn School of Medicine at Mount Sinai. She completed her residency in pediatrics and community medicine at Montefiore's residency program in social medicine. Dr. Flores is a board certified both in pediatrics and healthcare quality and management and is a fellow of the New York Academy of Medicine. Her career blends with clinical care, executive leadership, and advocacy, focused on advancing health equity, population health, and health literacy. She continues to mentor health professionals, teach at the undergraduate level, and provide care in the community. Dr. Flores is also the creator of the host of Unsettled Health, a podcast dedicated to exploring health equity, literacy, and advocacy through informed and compassionate dialogue.
Thank you so much.
You're welcome. Next is Dr. Diana Torres Burgos, who specializes in preventive medicine, public health, and pediatrics. She leads the National Hispanic Medical Association Advancing Physician Leaders Fellowship and serves as a research consultant for the University of Maryland's Consortium on Race, Gender, and Ethnicity. Dr. Torres Burgos obtained her medical degree from the Albert Einstein College of Medicine. She completed a pediatric residency at Montefiore Medical Center in New York and a second residency in preventive medicine and public health at the University of Michigan School of Public Health and the Office of Public Practice, along with an MPH in health education and behavioral health. She has extensive experience across the public and private sectors, as well as various leadership roles, driven by her commitment to addressing health disparities and promoting equity. She is passionate about advocating for a diverse and inclusive health workforce to meet the health needs of Latino and underserved communities and improve health outcomes. Again, for those of you that are joining, we're going to have a great talk today. It is currently being recorded. I'm going to share my screen and we will start. What I will say is any questions you have, please put them in the chat. And at the end, we will, I'll go over the questions. So I will be the advancer who will be speaking first. Diana?
Yes, Diana.
I just want to apologize beforehand that unfortunately right before this, I caught a cold. And so I will sound a little raspy, but I will try to do the best. I think both Dr. Flores and I really want this to be, educational, but also, to start a conversation as to what we can do in the environment, in the times that we're in. And so with that, I want to disclose that neither of us have any financial interest or relationships to disclose. So what we're going to talk about first, I think it's important to understand the U.S. healthcare system, how we are and how we compare to other countries, how much we spend on healthcare here in the U.S. We're going to look specifically at one of its major and the major program, which is Medicaid, and how it's going to be impacted by this One Beautiful Bill Act, H.R. 1, and the policy changes that it enacts. And then we'll go into a little bit more of the impacts directly here in New York, and what is it that we can do in terms of advocacy to be able to promote equity for everyone. Everyone thinks the U.S. healthcare system is a wonderful system, the best in the world, but in reality, we are the most expensive in the world when we compare to other high-income developed countries. So what you're seeing here is in 2023, the per capita expenditure cost per capita was about $13,400 plus. The next one after that was Switzerland, which was about $9,600. On average, most countries spend about $7,400 per capita. So we are the most expensive healthcare system in the world right now. And of course, there are always people monitoring things. And in the Bloomberg Country Index Fund, they followed, and in 2025, they found that the U.S. was rated on 34 out of 53 as being healthiest counties. So despite all the money that we're spending, we are not getting the same outcomes as countries that spend a whole lot less. And what makes us unique among all these other countries is that we are the only country that does not guarantee health coverage for all the populations in the country. We have most of what you're seeing in the other countries are single payer, and they have governmental insurance for all their population to at least service minimum needs. In addition, they may have some voluntary or private services, but everyone is guaranteed coverage through the government health insurance. As you can see, the US, only 38% of its population has health coverage through the government. The majority are private. And so that is called a mixed system where you have a mixture of public, private, also, co-insurance, co-pays, and different sectors. And so that's how we are unique in that we don't, guarantee health coverage, which is not a good uniqueness to have. There's monitoring that's going on and using different criteria to see who is the healthiest, but it's also, what are the outcomes from all these places? And so this is from a Commonwealth fund that looks at this every 3 years. And they do a report. Mirror 2024 is the last one that they did, in which they look at the US compared to all the other countries. And what you see here is rankings of access to care, where, as you can see, US is 10 out of 10. Care process, which is 10 out of 10. I'm sorry, care process, which is 2 out of 10. So there we're a little bit ahead of the game, and I'll explain what it is in a little bit. Administrative efficiency, again, 9 out of 10. Equity, 9 out of 10. Health outcomes, 10 out of 10. What was very interesting was at the conclusion of this report, they said the U.S. continues to be in a class by itself in the underperformance of its healthcare sector. What care process is that the country has the features and the attributes to be able to deliver high quality care. But again, it doesn't guarantee that you get good outcomes if it's not used correctly. And the fact that we are a mixed system and that we do not guarantee health coverage to everybody means that we have disparities. And then that again adds to the whole issue of having poor outcomes. So this is followed every 3 years, and I have to say from the previous report, there hasn't been much of a change. This is just an example of looking at, rate of infant and maternal deaths. The U.S. has the highest rate of infant and maternal deaths. If you look at infant deaths per 100 live births, the average through all these developed countries is about 4.1. We are at 5.4 in terms of the U.S. When you look at maternal mortality, meaning maternal deaths per 100,000 live births, the average is 9.8, and the US is 23.8. Very significant difference. We really stand out like a sore thumb. So we spend the most money of anybody, but where does this money go? How is it spent? In 2023, US healthcare spending was $4.9 trillion dollars. The healthcare expenditure per capita per person, what they spent was about 14,500 plus per person. That was about 17.6 of the gross domestic product in the US. Medicare was 21% of that expenditure, and Medicaid was 18% of the total expenditures. So when you look at what the service types are, over 50% of all this payment and spending goes to hospitals, physicians, and clinics. As you can see here, 31% to hospitals and 20% to physicians and clinic. Prescription drugs are 9%, nursing care 4.3, dental 3.6, home health care is 3.0, other professional services 3.3. What they mean by that are, OT, PT, optometrists, other types of care that wouldn't fall under physicians and clinics. And other health is, DME, all the things that are done, the administrative costs, everything just falls into that, including public health initiatives and programs. This is a very busy slide, but it's a very good slide because it really breaks down as to where all the money goes. And as you can see, the hospital and the physician services are the highest, both in private insurance, Medicare and Medicaid CHIP. You see long-term services, which are in purple, very, very expensive. and that is primarily paid through Medicaid. But there was one thing that's very significant about this, if you can look at it, and that's the pink. The pink is where the public health activities are. And again, as a public health physician, dear to my heart, you see that other health spending is about 563 billion out of the almost $5 trillion they're spending. But that's only about 30% of the other health services. So if you do the calculation, which I did, public health of the money that they're spending only gets about 3 to 4% of the dollars. So we are spending 3 to 4% of all the spending goes to preventive services, initiatives, and programs. We spend the rest of the money on treating disease and not trying to prevent them. And the percentage has been going down for a while now, where less and less funding is going to public health. So one of the major programs of the public health system of the U.S. healthcare system is Medicaid, in addition to Medicare, which is for seniors over 65 and others with health diseases like renal end stage failure. You also have the VA. You also have the TRICARE, which is military. You have all the clinics, FQHCs, some of which we consider safety net clinics. But Medicaid is the biggest, and we're going to go into detail on that. So Medicaid actually was created in 1965. It's a health insurance for low-income people that is jointly funded and regulated by the states, the government, and the territories. It's free health insurance to help children and adults if they meet income and other eligibility requirements. It has been shown that people who have the coverage, it facilitates their access to care, it improves their health outcomes, and it also protects them from financial medical debt, which is really important. Who is eligible for Medicaid? It varies according to state. It's eligibility by income and population, but those who are children, pregnant women, adults with children, older adults, people with disabilities, and childless adults. And both the government and the state government and the federal government regulate and fund. Medicaid is the only one that pays for long-term care. And that's a very important thing to note, because a lot of people, when they go on to retire, thinks that Medicare will pay for all that stuff, and it does not. Medicaid is the only one that pays for nursing home and pays for home-based services. So it's a very important thing that if you are having patients that are entering, senior years, that they be aware of this, because it's a big surprise for many people when they actually have the need. It also is CHIPS, which is Children's Health Insurance Program. And it's for children that are uninsured up to age 19 who live in families that incomes that are too high to qualify for Medicaid, and for some pregnant women. Again, that does not pay for long term. And again, it's regulated by both the state and federal government. Nationally, across the states, 1 in 5 people have Medicaid. And again, as we mentioned, it's all based on income eligibility, which is defined as a percentage of federal poverty level. This again may vary according to the state, and any resident, and it also varies in terms of any residency or documentation is required. Note that there are expansion states that with ACA, they expanded certain states to have higher thresholds of income. And there are 41 states and the District of Columbia that currently have expanded Medicaid under the Affordable Care Act. And this will help determine how low-income adults without children, families can actually get health coverage. It is the largest health insurer in the United States. It provides over 83 million low-income children and adults in the United States coverage. It covers 1 in 5 Americans. It covers 39% of our children. It covers half of our youth and children with special health care needs. It funds 41% of all U.S. births. It funds a quarter of all mental health and substance use treatments, and it covers 1/3 of working age adults with disabilities. And as you can see, it funds 61% of long-term care. When you look at U.S. healthcare coverage, as I mentioned, Medicaid and CHIP account for about 21.3% of all health coverage. The highest health coverage is private insurance group, usually employee-sponsored insurance, and that's about 54.7%. Then you have also Medicare, which is 18.8%. You have the military and the VA cares you see there. But right now, 7.9% of our population in general is uninsured, and this is across all populations. However, when you look among Latinos to see what type of insurance coverage they receive, you see that they 31, and here what you're seeing in this graph is a change from 2010 to 2022 among Latinos age 0 to 64, in that 31.4% are on Medicaid in 2022, as opposed to 26.9 in 2010. When you look at direct purchase, and this involves like buying into the marketplace, you see an increase of 5.1 to 9.1%. Employer-based, there was also an increase of 44.3 from 36.7. Very significant through all this, particularly the marketplace. The uninsurance rate of Latinos was at 32.7% in 2010. And as a result of the marketplace and other things that have happened, it's now at 18% in 2022. So this is looking at the trends from 2010 to 2023. And what you can see here are the uninsured rates by race and ethnicity among people under the age of 65, as I mentioned, from 2010 to 2023. And what you see is that in 2010, and I'll look at the Hispanics, we were at 32.6%. It was in 2014 with the Medicaid marketplace expansions occurred, and you started seeing going down. I think it was actually enacted in 2010, but implemented in 2014. And you started seeing a decrease in the number of uninsured people of Latinos and other groups. It also continued in 2020 because it got also more funding because of COVID. So right now in 2023, you see the decreased rates than they were compared to 2020, 2010. The only thing is that Hispanics still continue, along with American Indian and Alaska Natives, continue to be the highest uninsured populations in the United States. Speaking specifically about New York State and Medicaid coverage and spending, these are more recent numbers, 2025. There were close to 7 million children and adults that were enrolled in New York Medicaid. Of those 7 million, a little over 2 million of those were in the expansion group. The New York State Medicaid coverage is 36.6%. 78% of those enrolled are adults and children, which account for 41% of the spending. And then 21% of the enrollees are seniors or people with disabilities, and they account for 59% of the spending. But it's important to note that in New York, Medicaid covers 49% of births, 44% of children, 25% of adults between the ages of 19 and 64, 54% working age adults with disabilities, 30% of Medicare beneficiaries, and the highest is 64% of nursing home residents. And something that you have probably seen in the news and has come up is the new requirements that they want for work. Well, 71% of Medicaid adults are working, 44% full-time, 27% part-time. So it's very important to know these things to be able to give the facts as to what the reality is and not what people are supposing or presuming. When you look at the coverage by race and ethnicity, you find that 35% are white, 18% are Black, 31% are Hispanic, 6% are Asian, Native Hawaiian and Pacific Islander, and 0.5% are American Indian and Alaska Native. So being more specific to New York, this is the income eligibility in order for someone to receive Medicaid. And what you have here in blue is New York, and in gray is the US median. And what you see here for children, you could get Medicaid up to 405% of the federal poverty level. For pregnant women, it's 223% of federal poverty level. For parents, 138%. For childless adults, 138%. For people aged 65 and over with disabilities, it's 138%. And the highest income eligibility level for people aged 65 and over and people with disabilities is 250%. The federal poverty level in New York in 2025 was 15,650 for an individual and was 26,650 for a family of 3. This can vary by all states, but this is what we have for New York State. Again, it points out that we are an expansion state. So many expansion states elevated their income eligibility in order to have more people be eligible to receive services. When you look specifically at New York City, what you find is of the 36.6% in the state that are covered by Medicaid, 57.3% are in the city, and 42.7% are in the rest of the state. And when you even break it down even further to look at the boroughs, what you see here is that Brooklyn, the Bronx, and Queens have higher Medicaid coverage as opposed to the higher income boroughs of Manhattan and Staten Island. And you can see the rates here. So it just gives you an idea of the populations and the income differentials across New York City. So the One Big Beautiful Act, or the OBBBA, HR1, these are all different names that they use. So what is it bringing down? What is it telling us that the policy changes they want to make and the reductions that they want to make in terms of Medicaid? What it's doing is making key changes to Medicaid eligibility. It's requiring work requirements, which Dr. Flores will go into a little bit more detail. It's making eligibility tighter and redetermination harder, going from 12 months to 6 months. It's cost sharing now for expansion adults, so they're being asked to pay more. It's also affecting financing by the state and how they can get revenue to help cover the services. So expansion states have to phase down from the maximum allowable state that used to be 6%, which they want to reduce down to 3.5% by 2032. The other thing is they cap the state directed payments at either 100% or 110% of Medicare rates. So they definitely are reducing what they pay out. The thing that we're involved in now and fighting for is the expiration of the premium tax subsidies, which is due to occur December 31st of this year. And that significantly will cause increase in premiums. Premiums can go as much as 100% higher than they were before. So through this bill, according to the Congressional Budget Office, by doing all these cuts, the federal government will save 1.5 trillion over the next decade, but it will lead to an increase of the number of uninsured individuals by 11 million by 2033 because of all these changes that they're making to Medicaid in the marketplace. So as a result, we've all heard it. It's all been in the news. This is going to impact everybody. Here it says in many communities, whether rural, urban, or suburban, everyone is in the same way relying on Medicaid, at least to keep their hospitals and clinics open, and everybody's going to be hurt by cuts to it. And so there's a lot going on as to how we can avoid this and not have so many people get uninsured and not have access to healthcare. And we know that cost does affect healthcare. What you can see here, this is from the Kaiser Family Foundation, looked at the percent of adults who delayed or did not get health care or dental care due to cost. And what you find here is that Hispanic adults, non-elderly adults, adults who have worse health, and uninsured adults are more likely to delay or forego care due to cost. And so again, increased costs make it less affordable. People will have less access. So Medicare cuts will lead to less reimbursements to hospitals and providers. Again, as I mentioned, reduce access to care. The states will have limited options as to what they can do to be able to still continue providing the services they are, which could mean either increasing taxes to the consumers or redistributing whatever existing revenue there is and programs, where their programs may be cut, to be able to cover the expenses that they have. And with that, I will hand it over to Dr. Judith Flores to continue on to speak more specifically about the HR1 and in particular New York Medicaid cuts.
Thank you so much, Diana. And by the way, we need to give her a big hand because you are sick and yet you are here giving us all this great information. So applause, applause, applause for everybody. Let's move on to the next slide. So a lot of this, what Dr. Burgos has presented is national and a little bit of New York specific. But why New York? Why so much attention on New York? Well, New York is one of the two states that has what we call essential benefits. And even though 41 states do have expansion, essential benefits, which are benefits which are more impacted for people that are working, people that perhaps is the freelance photographer or the person who has a job and can't possibly be eligible for Medicaid because they are living way above the poverty level, but yet cannot afford private insurance. So in New York, we've had a lot of good coverage and access provided mostly through the Accountable Care Act in a shared manner from the federal government and the state government. In no way, and I want to make sure we talk about this right away, in no way, even though there's a lot of advocacy around getting people to get the state to cover some of these expenses, it cannot be totally covered by any state, even a state as well resourced as New York. But let's talk about just terms. So key issues, there's something called unwinding and redetermination in New York. So we all know we had a pandemic. We all know that under President Biden, the redetermination or review of Medicaid did not occur during the pandemic. So people that were on Medicaid had essential services, had expanded Medicaid, whatever they had, they stayed in the system. They did not have to reapply. However, as of September 12th of 2024, the actually a little bit before that, we had unwinding. So unwinding means that you start looking at people, start seeing if they're eligible, and in some cases, drop them. So when they are dropped, that is an administrative disenrollment. It is a very bureaucratic heavy process. It's a process where in the past, those of us who worked on the Accountable Care Act enrollment know that many people lose their care. So that's important to know that the unwinding is really a redetermination and it is going to impact people even, it has impacted people even more heavily. So implications of patient care and system navigation. Part of what I want to do today is give people a little sense of what we need to do as providers. What can we do as providers? What can we do as people that work in healthcare systems? The numbers that Dr. Burgos shared with us are extremely dire. I mean, 11 million people will lose their health care in the next decade. We're dropping children, we're dropping long-term care. This goes on and on. But what can we really do? Well, we work in systems, and the first thing we have to do is we have to get smart about coverage. It's not something that we usually do as physicians. We refer and we do a lot of authorization of workflows. We sign documents and make sure that people get the services that they need. But we have to remember that we have to understand managed care plans, the rules for Medicaid in New York. If coverage ends, patients may need new plans to be enrolled or may face delay. So yes, when I was training, we did not look at people's insurance. And even in the last few years, we were not worried about what your coverage was, but we have to now. We have to preempt and plan. In other words, we have to see, especially our patients who are getting any care, as patients with chronic disease, we have to anticipate possible disruptions in their care. So when their coverage changes or when their coverage is lost, remember, not only are we losing the financial funds from the federal government, we are shortening the period for someone to be re-enrolled, because annually was when people would be re-enrolled for their health, for their Medicaid benefits or their tax credits. Now it's down to basically 5 months because you have to get that patient and that person ready to re-enroll, get all the paperwork, get it in a language that they understand, all that stuff. We have a very short window now. So it's important to work with other team members in your facility to understand and appreciate that this patient that you're seeing may lose their care. So we want to look at resources. Many patients may not know their coverage has changed. Many people don't even know they're on Medicaid. I listened to some recent discussions actually on NPR, and people were stunned that they were on Medicaid. They were interviewing people in Louisiana and other states, and they said, well, I really don't care about this Medicaid business because I'm not on Medicaid. So they said, could you please show me your insurance coverage? And they'd show them the insurance coverage. Louisiana-based Medicaid is what they had. They didn't realize they had Medicaid. They thought Medicaid was for those poor, and I hate to use the word, lazy people, because I did hear it recently. So it's important to make sure the person knows what their coverage is and they work with whatever navigation services you have and preempt their loss of Medicaid. So physicians now and trainees really have a more advocacy role than we ever had before. You have to know your systems, you have to know what's available in your systems, and you have to be able to inform them and work with them. We are not expecting us as physicians or you as physicians in training to take all the time to do this on your own. You have a team that you work with, and if you don't, you can get people onto the New York State website and get them information. So checking coverage status becomes very important. Ask patients about their insurance at each visit. You don't have to do it, but make sure your front end staff is doing that. We can no longer just let people walk in and not make them aware of what they may or may not have within the coming months. Eligibility, enrollment, and redetermination. Membership and eligibility is based on income. We already talked about the federal poverty level, which is extremely low. And I made a little comparison. And what we spend on individuals in the United States for healthcare is about $14,000, according to the information that was shared by Dr. Torres Burgos. But the federal poverty level for that individual is about 15,000. So what does that mean? That means that you have to be very low. Your income has to be very low in order to be eligible for many things. The only thing that has saved us recently has been the Accountable Care Act, because it allowed people that were above that poverty level to move on into other forms of coverage, be they expanded Medicaid, be they tax credits. All those words are out there. But what they really mean, because I don't want people to get lost in the words, is that there is a mechanism in some states and in New York State where we can have coverage for people who otherwise are working, have children, are older, or have some kind of issue, or are single and are freelancing and would not be eligible for Medicaid. So we already talked about COVID and how during the public health emergency, we had coverage, and then we unwound that, and now people are falling out of eligibility. According to the internal data, New York State achieved about 82% renewal rate for redetermination process so far. Please be aware that that is previous to the HR 1. With the HR 1, we're going from an annual review to almost a 5-month review on each person. And we're also going to have more severe work requirements. Why loss of coverage matters for clinical practice. So we've already gotten a lot of this information, but when patients lose Medicaid or transition to another plan, let's say a marketplace plan, there may be gaps in coverage. You know this happens. You know that you're referring somebody for care and they don't get that care because they don't have the coverage. And as a pediatrician, I particularly am concerned about a lot of developmental referrals I make. Kids that need OT, PT, they need a developmental specialist. They may need some mental health, behavioral health services that they're not going to get because they're going to be in that gap of coverage. So from a clinician's point of view, loss of coverage may lead to delay in preventive care, increased reliance on emergency care, or interruption of chronic management. We all know this. What's going to happen, and we've already seen this, is because of loss of coverage, and in addition, some fear that we're seeing pretty much in our communities to even come for healthcare. People are going to seek their care later on in a more severe condition and usually in emergency care. And so our emergency services are really going to be very oversubscribed. And this is a point I make, by the way, when I talk to people about Uh, Medicaid affects us all. The loss of Medicaid affects us all. If I have my private insurance and I don't think that Medicaid is going to impact me or mine, remember that when I get sick, I'm on a queue. I'm going to be seen after the sickest person in front of me. That person probably lost their health care. So I'm going to be pushed back to the back of the line. The other thing is when I go to see my doctor. By the way, some of the providers' base has to do with their Medicaid funding. So if they start losing that in great numbers, the insurance costs for me and the reimbursables for them as practitioners is going to be much lower. And there are already providers out there that don't even want to take Medicare because they're not getting reimbursed at the proper rate. So patients who lose coverage may be eligible for a special enrollment period in the marketplace or other state-sponsored plans. This is something that we're looking at. I would say that that's something to pay attention to if that is going to be a possibility. But remember, with HR 1, the state cannot change the eligibility. The state cannot change the period of reassessment. So Families USA did an analysis in 2023, and the key findings were really that about 19.4 million low-wage workers from key industries rely on Medicaid. That means people that work in health insurance, also people that work and do not qualify for employment insurance. More than 7.3 million retail and service industry workers, including those in food service, hospitality, and maintenance sectors, as well as those who are cashiers and such. So it's 25% of retail and service industry workers in Alaska are on Medicaid. Why did I pull that out? Because a lot of people feel that it is only an urban issue related to certain states. 25% of social service workers in Ohio are on Medicaid. Social service workers work in hospitals. Nearly 20% of Pennsylvania's transportation workers are on Medicaid. 30% of Maine's farmers, fishers, hunters, and loggers are on Medicaid. So this cut is going to hurt us all. How is these cuts affect our ability to obtain higher education? We already know we're impacted by DEI. We know we're impacted by higher cost of tuition, especially in medical schools. So what happens when you are a graduate student or a medical student? Uh, does the school pay for our students' health care? It does not. You can purchase it at a cost, but it is not something that's available without cost. Can you get your parents to pay for your health care? Yes, if you're under 26 and they're working and they have insurance. If you are in your own state and you are eligible, you can get Medicaid coverage while you study. We don't know if this is going to be true going forward. This is a very important matter that I'm very concerned about, and I feel that we need more data on. And I know we have an audience here of some students and some researchers. I really think it's time for us to look at very carefully what is going on with Medicaid and our medical school students, especially those that are underserved, especially in New York State. That's an interesting study to do. I actually put it to LMSA, and they had no data as of a week ago. Students from certain historically disadvantaged racial and ethnic groups are impacted. Certain non-working students, if you're a medical student, I don't think you're working. Some students also face challenges getting health coverage. Affordability was an issue, especially in states that hadn't expanded Medicaid. Remember, I think it's 21 states expanded Medicaid, but there's still a significant number, especially in schools in, for example, Texas, Florida, North Carolina, Georgia, South Carolina. They're all that the Sun Belt does not have this feature. Coverage was geographically limited, as I said, leaving out-of-state students without access to care while at college. So if you're going to school in, let's say, Georgia, and you're not a Georgia resident, you're not eligible for Medicaid. Advocacy and equity, what you can do now. Let's start with the definition. Health equity is achieved when a person's characteristics and circumstances, including race, ethnicity, sex, gender, identity, sexual orientation, age, income, class, we can go on, disability, health, immigration status, nationality, religious beliefs, language proficiency, or geographic location do not predict their health outcomes. The magnitude of the cuts, I think we've gone over a little bit of this, but it's worth listening to again. Nearly $1 trillion in cuts to Medicaid. That will eliminate healthcare coverage for 10 million people in 2034 with the expiration of enhanced premium tax credits. That's the ability of people to be able to obtain coverage even though they are working, even though they cannot qualify for Medicaid. That is a very typical credit and a typical benefit that we have in New York State and also in the state of Minnesota. So it's not pretty much a national benefit. This is unprecedented. This is the biggest cut in Medicaid history. And the theme is basically that extra hurt for Medicaid expansion states. The extra hurt is for New York State. Medicaid expansion states, as I already said, potential coverage losses are among adults ages 19 to 55 under Medicaid work requirements for expansion and enrollment. So you can read this slide, but I will tell you what the work requirements are. Work requirements for Medicaid. Okay, this is extremely important. You already heard that most people on Medicaid work either full-time or part-time, especially in New York State. But the requirements are going to be that adults have to have community engagement. So it's not defined as a work requirement, but a community engagement. Although states may implement earlier or obtain good faith efforts delay. You can't have, what that means is the state does not determine the criteria. The state cannot overrule what is in HR 1. So the mandatory requirements for Medicaid enrollees and applicants are from ages 19 to 64. They have to do at least 80 hours of qualified activity per month, 40 hours if in school. 40 hours if in school, I repeat that again. That applies to Medicaid expansion and partial expansions. It must show evidence of community engagement with prior month and at application, so up to 3 months, and renewal. That means that you have to show when you renew at least 3 months of having the qualification for this expanded work requirement. Individuals who lose or are denied Medicaid due to work requirements are locked in out of marketplace. If you lose your Medicaid, you can't turn around and apply for the expanded marketplace subsidies. You can't apply to a managed care company under Medicaid. You're working and you want to apply, you want to get the tax credits, can't do that. Once you lose Medicaid, I think you lose it for a couple of years and you are ineligible for marketplace subsidies. So there are some specific excluded individuals. Medically frail or special medical needs. This is something, by the way, that has possibilities because I was just at a very large conference, and one of the things that people are looking is who can we define as medically frail? Are people with HIV disease that don't get other coverage medically frail? Who is going to have special needs? How can we define that? That can be defined within the state. Parents or caregivers of dependent children. So if you have a child under 14, you don't have to be working or prove that you're working. If you're a parent, guardian, or caregiver of a relative who has disabilities, you also don't have to prove it. If you're a veteran with a total disability, so if you just got out of the armed forces and you have no disability, you are not going to be excused from this work requirement. Participation in a drug or alcohol treatment qualifies as an exemption. Compliance with TANF requirements. TANF is a work initiative, and it's been in effect for many, many years. It implies that you are working. If you're in a household that receives SNAP and is not exempt from work requirements. American Indians and IHS are exempt from this. Why? Because the American Indian Health Service is a separately funded program and it is not Medicaid based. Pregnant or entitled to postpartum services, you don't have a work requirement. And if you're an inmate in a public institution, I guess you don't have to go out to work. More frequent eligibility redeterminations. So again, what I said before was that the state must redetermine eligibility for people on ACA expansion every 6 months, twice as frequently. And in order to make that 6-month determination, you have to start getting ready about every 5 months. More frequent redetermination increases risk of procedural determinations and increases burden on people with disabilities and increases state administrative workload. So you're spending more money trying to determine the eligibility of a population rather than covering their health care needs. Shortened retroactive coverage. This is a particular problem for healthcare institutions. If you're working in a clinic, if you're working in a hospital, let's say you come in and into the clinic and you want to have healthcare services, but your Medicaid is still not in effect. So usually institutions can look back for 3 months and get paid for those 3 months. This is no longer going to be the case. They can only look back for 1 month and 2 months for all Medicaid recipients and 1 month for expansion adults. Anybody on the expanded Medicaid, they will only have 1 month. So do you think providers will be very interested in receiving patients that have Medicaid, that are on Medicaid, if they can only get retroactive benefits for 1 or 2 months? It's going to affect the access and the ability of providers not only to provide the care, but to exist. This is the kind of thing that may cause closures to hospitals and services. Higher out-of-pocket costs. Effective October 1 of 2028. It's not that far off. So states must impose cost sharing for expansion populations. This is the tax credit issue. So what happens is right now you can get services because if you're not eligible for pure Medicaid, you can get services if you're working up to 400% of the federal poverty level. This is going to be reduced at 100% of the federal poverty level. For most services, you're going to exclude primary care services, behavioral health care services, etc. The state will decide that an amount less than $35 per service and an aggregate limit of 5% of the family income. All that means is that now when you go for your care is going to cost more. Your expanded care is going to cost a lot more. If a plan that you worked in through the marketplace gave you tax credits that would reduce your payments down to maybe $100, $120 a month, will now be increased to $500, $400 a month. I'm just giving you broad numbers, but think about it. Would you be able to afford that? Probably not, because you have to make your housing payments and your food payments and everything else you need to survive, especially in an expensive place like New York. We know that people that are undocumented in the United States do not get Medicaid. That's a given. But effective July 4th of 2025, okay, this was when the HR 1 came into effect. They're restricting Medicare eligibility to U.S. citizens that have green card holders after 5 years. So it's restricted. Cubans and Haitian entrants and people lawfully residing under a compact of free association. Okay, they're restricted. There's the effective 2027 terminates Medicare for all other currently eligible lawfully present Medicare enrollees. So if you're enrolled in Medicare now and you are part of these restrictive Medicare populations, you're going to be losing your Medicare in 2027. Effective in 2026, there'll be limits to the eligibility to the same group as Medicare Medicare above, and the states retain flexibility to cover lawfully present pregnant women and children. So that's really all the wiggle room we have. Lots of people that otherwise were eligible for Medicare that are recent arrivals and are lawfully present in the United States are going to be losing their Medicare by 2027. So what can be done about all this? It's a very difficult conversation to have and go through this litany of what's going to be cut, what's not going to be available. It really sounds very dire, but there are things that we can do because we've been hard positions before. And we can do things. First of all, building coalitions and relationships with a variety of stakeholders to get different perspectives on how to mitigate the harm, improve outreach to the community, and increase innovative ways to continue to fund programs. What does that mean? That means you have to have partners. That means you get to know the communities that you serve, get to know what organizations are out there to support people when they're going through this. Consumer education, educate yourself just like we're doing here this evening. Find out who's eligible, what are the changes, especially in the communities that you will be serving, and for yourself, because if you are a student or you are going to be impacted by a lot of this. Interested Parties Advisory Group, that's again building coalitions. Leverage the Medicaid Advisory Committee Beneficiary Advisory Council to develop recommendations to the state and to obtain necessary information. That's a really good resource. It's a good resource to have and to bookmark so you know what's being changed and who you can work with if you're so inclined to do more advocacy. Tracking implementation of work requirements, implementation of the 1915 C11 option, and cuts to rates. What does that mean? That means people have to learn to track what they do, track what work they do, whether they're doing community service, and have someone to be able to write that letter that says that they have been working and contributing. Tracking implementation of work requirements is going to be very important, especially for people that have any disabilities. Consider the role for managed care organizations. What is going to be their role? That depends state by state. And I know we have people in the audience that work with managed care organizations. Maybe they can give us a little more information. We also have a limitation on data, outreach, and assistance. A lot of this is going to require lots of navigation. People don't speak the language, don't understand what's happening, would rather just let it kind of go by the wayside and then end up with no access to care. So the different stages of implementation, advocacy is going to be required. And it'll make a difference depending on how strong we are in being informed and being in partnership with organizations. So New York State healthcare system will be impacted significantly by these Medicaid cuts. There's no doubt about that. We need to be prepared. Medicaid is the largest source of federal funding to the states, so cuts could affect us all. Remember, these cuts are justified because there's going to be a major tax cut to Americans in 2027. I think that's when it comes into effect. And major resources for Border Patrol, ICE, and other governmental efforts to do what is on the agenda. So thank you very much for listening and for sharing, and I hope we have some questions that Diana and I can answer. Thank you very much.